Well, hello. Welcome. Good afternoon, good morning, good evening. Got that one backwards. Well, wherever you're joining us from, you're all very welcome. We're just going to wait for a couple of minutes to allow people to join. To say a brief hello. So my name is Benedict Michael. I'm a professor of neurology and a consultant neurologist working on neurological infection here in the Infection Neuroscience Lab at the University of Liverpool in the UK. It's an absolute delight to have you all here. As you can see, I'm joining you from a very sunny Liverpool this afternoon, but probably not quite as sunny or quite as marvelous as the wonderful Lagos in Nigeria, where our chair today is joining us. In a brief moment, I'll introduce the chair, who will then go on to introduce the panel and our speaker today. And it's really wonderful to have a diverse group of people in terms of specialities, interests, and of course, geography. If you wouldn't mind putting where you're from in the chat and what your specialty is, that would be great, just so we can say hello. But there'll be an opportunity, I think, further in today's discussion to also tell us a bit about where you're from and some of the issues arising from the presentation today. So, well, without further ado, it's a pleasure to welcome Professor Okubadejo, who's a professor at Lagos in Nigeria, who's going to be chairing today and leading the session. Welcome, and thank you so much for joining us.
Thank you very much for the kind introduction. My name is Njideka Okubadejo. I'm a professor of neurology from the University of Lagos. And our speakers today, our main speaker today is Dr. Arina Tamborska. But before I introduce Dr. Audrey Lorraine Chishimba from the University of Zambia. She's a neurologist. And we also have as a second panelist, Dr. Temitope Farumbi, who's a neurologist with a special interest in geriatrics at the University College Hospital, Ibadan in Nigeria. The main speaker, like I said, at today's exchange is Dr. Arina Tamborska. Arina will take us on a tour through the current state of play of neurological care worldwide and provide insights into tools that we can deploy to expand neurological health coverage worldwide, including in underserved areas. It's really exciting to be able to focus on this topic because it's something that's important, given that neurological disorders are one of the most important in terms of the burden of health needs globally. Dr. Arina Tamborska is a neurology resident and a clinical researcher based in Liverpool in the United Kingdom. She trained at the University of Edinburgh and at King's College London, and she undertook healthcare strengthening projects in Tanzania and Sierra Leone. So she has some insight into what goes on in the neurology atmosphere in Africa. She's active in COVID-19 neurology research, and she led the UK surveillance for neurological events following vaccination. Arina's broad interests include cerebrovascular diseases and neuroepidemiology, and it's a delight to find that she'll be joining the Harvard School of Public Health.
Thank you very much for this introduction. I'm just gonna take a second to pull my slides up and hopefully everyone can see them now. Thank you to the organizers as well for inviting me and trusting me with what is a hugely important and really also big topic to cover. Books have been written on universal health coverage, and neurology is not an easy topic. So we have a lot to cover, and I'm hoping to give you a good whistle-stop tour of, first of all, where we are, number two, where we need to get to, what are the challenges, and then also what are the possible strategies we can have. So we have an hour, so let's get started because there's a lot to talk about. So first comes first is the definitions and essentially about what we mean when we say universal health coverage. And this is the definition from WHO, which says that essentially it is for every person to be able to access the healthcare they need, when and where they need it, and also not suffer any financial hardship as the result of it. So this is a really sort of ambitious definitions, but of course we are talking about the healthcare, and really anything less would not be ethically accurate, I think. And it extends not only into the sort of acute treatment provision, but also to the prevention and also rehabilitation and palliative care as well. So with that, we're going to have two parts today. First will be the exploration of the background and, as I said, where we are. And the part two will be about discussing particular actions. And I'm also looking forward to engaging our panel because I think we have a breadth of experience here today with our discussants. But first of all, let's learn a little bit about you as well. And I'm looking forward to meeting our audience. We should have a survey popping up on the screen now, hopefully. I want to know a little bit about your background, whether you're coming from a neurology or non-neurology background, and which sort of WHE region are you based at? So just to see what sort of spread of audience we have. Brilliant. So about 50% of us are neurologists, so we are very awarely sort of acute of the different pathways and issues with accessing the healthcare. Welcome to those who don't work in healthcare and also those who are from allied healthcare professions as well. And I can see we have a good spread, sort of 4 continents represented. So I think that's really lends us to really good discussions in the question and answer part. So I'm going to keep you on your toes. And I'm going to move now on to the first part of our talk, which is what's the demand for the neurological healthcare? So what's the starting point when we want to develop the universal health coverage? And with that, I'm going to launch another survey, please. And this will be 3 questions just to test your knowledge on the topic and just to keep your attention going. So if we have question 1 appearing now. The first question is about how many people worldwide suffer from neurological disorders. Is it 1 in 6, 1 in 10, 1 in 20, or about 1 in 100? So I'm going to give 20 seconds for everyone to answer that question, and then we're going to release the answer. Okay, so if we could see the answers now about how the answers are distributed. Very good. So most people going for the first 2 options. So I think most of our audience is acutely aware of what a huge burden neurological disorders are. I will release the correct answer in a second, just to keep your attention going. That will be in the slides. Survey number 2, please. So which of these conditions constitutes over 60% of disability related to neurological disorders? In other words, what are the biggest 2 drivers behind neurological disability globally? So not specifically in your settings, but thinking about the sort of whole world population. Okay, so stroke and dementia on the top place, and then a sort of stroke and meningitis and stroke and migraines having equal division. So once again, I will release correct answers shortly. So this is just to test you. And the last question in this theme, if we can pop it on the screen. It's about what proportion of people with neurological disorders live in low and middle income countries. So it's the last question about sort of what burden we have and how it's distributed, and whether it's about a third, whether it's almost a half, over a half, 70%, or almost 90%. And for reference, I will say that about 90% of world population lives in low and middle income countries, and about 10% of world population lives in high income countries. Okay, brilliant, 70%. Okay, very good guess. So now I'm gonna quickly talk about the burden of the neurological diseases. And if you stay tuned in, you're going to find out the answers to those questions. So first of all is the source, and essentially where we take the information from. And in my opinion, I don't think there's a sort of a more comprehensive insight that we can get into the burden of neurological disorders than the global burden of disease study. And this is the study that was actually originated first in 1990 at the University of Washington with about 400 collaborators and covering just over 100 countries. And it had multiple editions since, and it now grew in the latest edition in 2019 to 5,000 collaborators and information over 200 countries. So really sort of good coverage of the global situation. And there are sub-analyses there specific to neurological disorders and specific to country level data. And specifically, there are publications that, for example, would look exactly at epilepsy or multiple sclerosis, for example. So this is a great source of information. And I encourage you to look at the specific publications for neurological disorders, but also to explore the website, which is healthdata.org. And it's a fantastic tool for data visualization, actually exploring and comparing different settings. And one thing I wanted to highlight as well is that it's open to collaborators. So it's very easy to apply to also contribute to the study, which is a great opportunity you might be interested in. So what have we found out from the global burden of neurological diseases subsection of the global disorder study? Essentially, as has been already outlined in the introduction, neurological disorders are the top cause of disability worldwide. So they contribute to over 270 million deaths, so years of healthy life loss, be it either because of death or because of sort of substandard health. They're also second cause of mortality globally with 9 million deaths. and essentially the sort of only other group of disorders that compares to that are cardiovascular disorders, which are the first cause of mortality and the second cause of disability worldwide. 1 in 6 people worldwide suffer from neurological disorders, so points to those who answered correctly, which I think was majority of our respondents. But I think one thing that is worth highlighting here as well is that the burden is increasing. Now, when we actually adjust for age, we see that we've made improvements. So there's less disability per an individual suffering from neurological disorders, which is on one hand good news because we are making progress and we are making improvements in healthcare. But on the other hand, what it tells me is that we are not really catching up with the demands of the neurological disorders. So as our population is aging, we're actually not being able to catch up with the increasing demand. Good news are only for conditions related to neuroinfection, so specifically meningitis, encephalitis, and tetanus, where the sort of global burden is decreasing, and so is age-adjusted burden. In terms of the conditions which are the primary drivers, it might come as a surprise to some of our audience that's actually the headache disorders alongside with stroke that are the 2 main drivers of neurological disability worldwide. And meningitis and dementias together with Alzheimer's disease come in 3rd and 4th place. In terms of the mortality, once again, stroke is a primary driver worldwide, and dementias as well, which are increasing in prevalence. This is just a distribution of what are the primary causes of disability worldwide in different regions. So as you can see, stroke and migraines are the primary drivers in the sort of 1st and 2nd place in most settings. But you will also see that certain settings, epilepsy will be higher up, which will be primarily driven by demographics. But also in others, conditions such as tetanus, particularly in sort of Eastern Africa, will be driven by low vaccination rates, particularly in Somalia. And actually tetanus is the 6th biggest cause of neurological disability in those settings. So I think what it tells us, and something that we'll talk about in a second, is that all approaches need to be driven and really adjusted for the settings. And it's not only about the sort of global policy, it's also about making local policies which are adjusted to what we see on the ground. Distribution, as there was another poll question, it is 70% of all people with neurological disorders that live in low and middle income countries. And really I'm highlighting it because this is obviously a huge number, and traditionally we used to think of sort of the division between communicable and non-communicable disorders, but actually even for dementia, which is a condition of primarily aging population, already 60% of all people living with dementia live in low and middle income countries. And unfortunately, this is where there is less provision as well. So moving on, it's what we have at the moment. So we talked a little bit about the demand, and now we're going to move on to talk about the current state of play. So what are the services available worldwide? And once again, you know, I cannot cover everything because it's a huge topic, but my role here is to sort of point you towards really good resources. And for provision, I think one of the best resources available is actually the Global Atlas of Neurology, which is published by WHO, and it's currently on the 2nd edition from 2017. It is due for an update, but as with the COVID pandemic, obviously, there were also other priorities in the last few years in the world. But what I like about the Atlas really is that it shows us that it's not just the provision and often, you know, what we think when we are doctors on the front lines. It's not just about the workforce and the number of neurologists per number of population, and it's not about the access or how many MRI scanners there are. What Atlas really captures is that this, for universal healthcare provision, we need the things upstream and sort of downstream. So we need planning, we need policy and legislation for neurological disorders, and we also need plans for dedicated budget that is specific to neurological disorders and that cannot be sort of shifted to other competing needs. And then, you know, after the sort of provision on the ground, it is also about having standards, having guidelines, so we know what we are aiming for. And it's about having information gathering systems so that we can measure whether we are adjusting and sort of achieving the standards that we are aiming for. So it's just really to show that, you know, this is a multi-theme area with multiple themes to address. Now I wanted to pull out some key messages from the Atlas. We've talked a little bit about the information gathering systems, and actually only 50% of countries in the world have information gathering systems on the number of cases of neurological disorders. Only 20% of countries have a dedicated budget, and in just over half of countries, you can have a guarantee that you will have an anti-epileptic medication, at least one, available at all times. So certainly there is still a lot to do, and workforce still comes into it. And here I sort of put the numbers for neurological workforce worldwide, which vary between low and high income settings. But I think for me, the comparison is that actually even in high income settings, even in Europe, based on the information published by the European Society of Cardiology, we have more cardiologists than neurologists per 100,000 of population. And cardiological disorders are comparable, are in parallel with neurological disorders. So we should probably be really aiming for the same numbers, but we don't have as many neurologists. And that's why most of the neurological healthcare is provided in primary settings. But what is also striking to me is that actually we don't have information or very scanty information about the quality or the expertise available in those settings and the diagnostics available in primary care for neurological disorders. So before we move on to the panel discussion, I wanted to sort of briefly mention that it's not really about comparing country to country and saying, well, it's obviously, you know, much worse in low income settings than it is in high income settings. It's about also taking a magnifying glass and saying, well, actually, how are we doing on one country level? And here what we see in this slide is actually, if you go to a capital city, almost in all countries in the world, you will have a neurologist in the capital city. Whereas if you move to the rural areas and sort of suburban areas, even in high income countries, in only 50% of them, there will be a neurologist outside of the city settings. And I think, you know, I really hope this session is also an interactive discussion. And I was hoping to sort of briefly mention my UK experience in this setting, meaning that this is, for example, one area that's particularly visible in the UK. And if you present with an acute neurological condition and you are not in a major city hub, it might take a number of days as opposed to sort of same day review, sometimes by neurology, if you developed an acute neurological problem in a sort of a big city or a capital city. And similarly, we have also very uneven provision of our best neurological treatment, which in my opinion is thrombectomy for acute stroke, with numbers needed to treat just 2. It is sort of the most effective treatment we have in neurology. But actually at the moment, if you're a patient who suffers a major stroke, a large vessel occlusion, and you are not sort of within a proximity to thrombectomy center, and it's not Monday to Friday, 9 to 5, you will struggle actually to access those treatments. So I think what I'm hoping to say, even within the UK, there are huge interregional divides. And there are challenges related specifically to neurology, with the fact that our conditions are often chronic. You know, there's huge disability related to neurological conditions, and also diagnostics are complex and expensive, and so are our treatments. But just to highlight those areas, I wanted now to draw from our panel experience and also open it to our panelists to ask what's their experience, what's the pathway in the countries with accessing neurological care, what's available, and how they see the greatest challenges. So over to the panel.
Thank you, Arina, and thank you for this initial introduction to what is the burden of neurological disorders globally and what some of the challenges are. I'd like to first invite our panelists to share their experience with respect to the panel questions. And I'd like to confirm that Audrey Chishimba and Tope Farumbi are unmuted and able to answer.
Yes, we are muted.
Yes.
Great. So thank you for joining us. The first question is with respect to the access of patients to specialist neurological expertise where you work. So Tope works in Nigeria and Audrey works in Zambia. So I'll open it first to Audrey. Audrey, what's the access or patient pathway to specialist neurological expertise in Zambia, and who covers that access or who provides it?
All right, thank you very much, and good afternoon to everyone. So I'm based at a public facility, the University Teaching Hospital in Zambia. It happens to be the tertiary facility, the referral center for the country. At least it's been the longest tertiary facility in the country for a long time. A few other centers are becoming tertiary facilities outside of Lusaka. We haven't had neurologists apart from expatriates, but now we have about 9 neurologists that were trained following a program that was introduced for training in 2018. So previously, obviously, the patients would have to go through the district hospital at a local facility. They wouldn't access a neurologist right there and then, because at those facilities, there is no specialist in neurology. And then the second level hospital would be a provincial hospital, but even there, we haven't had any neurologists at that level. And so the patient has to go through these 2 steps before they are referred to the national hospital, which is the University Teaching Hospital. That's where you find the neurologist specialist. And that can take a little bit of some time, particularly because of the distances that these individuals have to cover to come all the way to Lusaka. We're talking distances of about 400 to 500 and plus kilometers to access a neurologist in the province, in the capital of Zambia, for instance. And currently, as neurologists, we are providing the neurologic service, but it's not everyone who gets to eventually get to be seen by a neurologist, just because of a few of those challenges I've mentioned, particularly the distance that they have to cover to access a neurologist. But when they do have to access a neurologist, they have to come all the way to Lusaka.
Okay, so Dr. Farumbi, has your experience been different, seeing that you practice in Nigeria? I'd like to specifically address the issue of how patients access specialist care where you work.
Yeah, thank you very much for this wonderful discussion. Sadly enough, our experience hasn't shown much difference from what Dr. Adri just mentioned right now. Let me just give you a broader perspective. In Nigeria, we have about 220 million people, and only 80 neurologists, registered neurologists in the country. And most of these neurologists are skilled and are more in the urban center, whereas the rural community that has about 52% of dwellers of Nigerian community don't have any neurologists at all. And if I say from my own personal experience, having worked in a tertiary center here in Ibadan, Nigeria, oftentimes we get to get referral from secondary care or primary care. We don't have neurologists at the primary care level, and as well as the secondary care level, we only have at the tertiary care. So that means that oftentimes by the time patient gets to us is almost late. They come in a late stage of their clinical condition, and even stroke that you need to attend to immediately. A stroke can come to you maybe 2 weeks after the initial incident. So these are the experience of neurologists in tertiary center. And also another particular thing that we have experienced is lack of awareness about where to go to, who to talk to, and even lack of expertise of the primary care provider to immediately refer a patient. So these are the experiences that we have faced. And oftentimes when the patient comes, we could only do very little. And another experience also is the lack of fund and support. There's no 70% of Nigeria pay out of pocket, and most of neurological investigations that you want your patient to do are very expensive and way out of reach. Even medication also, it's very limited to access. Most of our medication are, you don't get to prescribe as you want to prescribe, and because it's not provided and also it's not available. So the experience has been very horrible, but we are working within the limited resources that we have. Thank you.
Thank you, Tope. I also want to encourage the audience to share your experiences in the chat regarding how your patients access healthcare in the setting where you work. I know that the experiences are probably going to be very similar if you're in a resource-limited area, even within high-income countries. The other question is with respect to neurological diagnostics and treatments provided in your setting and under what financial arrangement. So Tope has started to address that in mentioning that is out of pocket for a large proportion of participants. So Lorraine, can you address what neurological diagnostics and treatments are provided and under what financial arrangements in your setting, but please keep it very brief.
All right, sure. So we, at our facility, we're able to do MRI, we're able to do CT scans. With regards to the number of these facilities or these machines, we only have one at the moment at our facility. We do depend on the surrounding private facilities sometimes when our machines are down. With regards to investigation, again, for example, if you're going to look for myasthenic serum antibodies, for example, we don't offer those at our public facility. And so the patients have to get to another facility, to a private laboratory to do those investigations. We do now have insurance coverage. And so this has helped us a little bit with regards to imaging, for instance. And our insurance institution was implemented in 2019. So that has sort of helped with the delays that we used to have, where you'd find just to do an imaging, especially for cold cases or chronic cases, you wait many days to get a imaging. For now, I can just say that.
Okay, and certainly it does seem that this is the best case scenario because you're working in an urban center. It's likely that in rural areas, the situation is not so. So to help us move along, I'd like to put a question to the audience. Indicate in the chat what your greatest challenges have been with respect to access to neurological care for the area where you work. So just drop your responses in the chat and we will look at them and discuss them in the chat or discuss them later as we go along. I'd like to hand back now to Arina in the interest of time to go on to the second part of her presentation.
Thank you very much. And thank you for those insights. I think that really highlights things that we know about and also showing that lots of, it's probably unrealistic to expect all neurological healthcare to be provided by neurologists. So I think that also answers sort of questions about what can be provided in the primary settings and how we can ensure training and sort of sufficient resources and expertise in those settings, sort of more rurally to sort of expand coverage of neurological healthcare. And I will talk about it in a second. So moving on then, onto the second part of the talk. It's about the action and action on the sort of highest level that has been taken by WHO, but it's also about more local examples and showing different sort of activities or actions that we can take to help to improve situation. So with that, let's hope to launch another survey, please. Again, keeping you on your toes and making sure you stay engaged. So if we have questions appearing now, please. And the first one is really easy. It's just really to test the awareness of the WHO Intersectoral Action Plan for Neurological Disorders, which is a sort of new landmark publication from last year. So just clicking yes or no if you've heard about it before this talk. So most of our audience actually have not been aware of this. So I'm really pleased that you are here because that was one of the outcomes I wanted to achieve, was to spread awareness of this. And I'll talk about it in a bit more detail in a second. So let's move to the second question in this part of the survey. This will be difficult for those of you who have not heard about the Intersectoral Global Action Plan from WHO, but you can always take a guess. One particular condition gets special focus and special mention, and there are specific action plans and objectives related to that condition. And is it meningitis, is it stroke, epilepsy, dementia, or is it multiple sclerosis? So you can select your guess about which one is sort of receiving highest priority on the WHO IGAP agenda. So rightly so, many of you said it's stroke, and epilepsy and meningitis sort of receiving similar answers. Yes, multiple sclerosis is not one of those, you're right. So I'll confirm which one it is in a second. And the third question in this part of the survey, please. What's the timeline of the IGAP? So it is quite an ambitious plan with a few objectives. What is the timeline that the WHO decided they'll try to implement those 5 strategic objectives? Is it a 1 year plan, 3 years plan, 5 years, 10 years, or is actually timeline not specified and it's sort of just an outline of where we want to be in general? Okay, brilliant. So it's a 5-year plan according to most of us. So once again, so keep on listening and I'll answer all those questions and also hopefully raise awareness of IGAP among our audience. So IGAP was established in 2022. So it's a last year document. It's a landmark document because there was no previous action plan from WHO on neurological disorders. Essentially the vision of IGAP is quite broad. You know, it's a very ambitious plan of the world in which brain health is valued, promoted and protected. In which all neurological conditions are diagnosed and treated correctly, but also the world in which there is sort of provision for human rights and protection against discrimination for people with neurological disorders. Specifically, it's been a work of several years and it builds on the previous documents that I talked about. So it builds on the global burden of the disease study, it builds on the WHO Atlas, and then a recent global action on epilepsy and on neurological disorders. And it is a 10-year plan, which was sort of carried out in consultation with the member states. And it has 5 main objectives with actions for the member states, the WHO itself, and also for national and international charities and NGOs. And as you can see from the top of the slide, the particular condition that gets special mention is the epilepsy in IGAP. So now very briefly, I want you to be aware of the objectives and how WHO has sort of identified and specified those. The first one is about raising the profile and prioritizing neurological disorders. And then a sort of expectation and the aim there is that WHO wants 75% of the countries to have national policies and all countries to have at least one functioning awareness campaign on neurological disorders. The second point is the sort of the bulk of work and what we talked about in the break and what we often see as the sort of the core and the stem of neurological provision. And it's about including neurological disorders in the health coverage and the benefits coverage. And it's also about ensuring these essential treatments and basic diagnostics available. The next objective is very important in my mind. It's about sort of promotion and prevention. And as I said previously, our population is getting older. It's getting older worldwide, and we are not really catching up with those numbers. And that's why the burden is increasing, even though we are perhaps better with management of individual cases. So WHO does want at least 80% of countries have at least one intersectoral program for promotion of brain health. Then number 4 is about collecting and gathering data, and it's about the governments. So it's about increasing the research output on neurological disorders, and it's about having those systems in place that actually allow us to measure and know what the situation is. And as I previously mentioned, in many places, neurological care is and will have to be provided in the primary care settings, but we have very little data on what level of care is actually available in those settings and what level of training and expertise is available to patients. And then the 5th point is about the special mention epilepsy, and it's about increasing the service coverage and also about giving that legal protection to people with epilepsy against discrimination. So a very sort of noble and important aim. So then we move on to the execution, and I'm going to talk about examples of the things that have been done on sort of high level and also lower level to actually try to work towards those objectives. And to me, prevention is the biggest and the most important one of those, because we cannot just increase provision. You know, this is challenging, this is difficult. We need to make sure that we see less neurological disorders, and that if we see them, we can delay their onset in life. So it's about people getting dementias later on in their life, avoiding early onset dementias, minimizing risk factors for those. And here really stroke and dementias, particularly vascular dementias, are the areas where we have very good evidence that we've actually built over the last 10 to 20 years on sort of decreasing the burden of those diseases. And effectively, it's, you know, things that are good for your heart are good for your brain. But how often in the media do you see adverts saying, you know, don't smoke, smoking actually causes dementia? Everyone knows that smoking causes brain cancer, causes lung cancer or causes shortness of breath. But actually, we do have to link with those other campaigns for other non-communicable diseases, and then say, look, all those things are actually also important for brain health, so we can increase and promote the message. It's also about solutions on the national level. So it's about taxing, it's about increasing tobacco taxing, alcohol taxing, and then using the income and the revenue from those taxes to then reinvest in promotion and reinvest in training of neurological workforce. It's about managing air pollution, and actually we have now good evidence that says that pollution, indoor or outdoor, increases your risk of dementia, yet there's definitely much more that could be done, be it sort of even in high income countries in terms of reducing the traffic emissions, and also about sort of exchanging the stoves and ensuring clear air indoors. It's about smaller interventions. It's about tech and increasing, for example, access to apps that can inform you of your individual risk and can promote healthy lifestyle, for example, exercise apps, stroke riskometer apps. And then outside of stroke and dementias and apart from cerebrovascular diseases, it's about preventing things like traumatic brain injury and increasing legislation about the road safety. And it's about preventing conditions which can be prevented with vaccinations, and particularly we've had successes for meningitis and encephalitis. And the new hot area is whether we can actually promote vaccination against EBV virus to reduce the rates or actually stop new incidents of multiple sclerosis. So there's lots to explore in that area. And it's about increasing our research in prevention. So not just the disease mechanisms, but also knowing what actually works, what is cost-effective preventive strategy, and what preventive strategies are actually acceptable in different settings, and having the local knowledge and the local understanding. Next is sort of the big fish, which is the provision. And this could be a separate talk. It could be a separate series of talks. But essentially, it is about increasing the training and increasing the resources also in primary care, and also about task sharing and delegation to sort of not only neurologists, but also other allied healthcare professionals. And it's about, for example, in urban areas, about increasing access, for example, using telemedicine. And we've had good experience and good evidence from COVID pandemic, which shows that actually remote assessment of neurological conditions can be an effective way of making clinical decisions. Then it is about defining what constitutes actually minimal, essential, and advanced level of healthcare. Defining what interventions and what treatments should be available within those levels, agreeing on them, and then defining, this country is actually at the moment in the sort of essential, and what can we do, what should we do to increase the coverage, to put it to the sort of advanced level, and then say, well, specifically that means we should have a coordination on national level, for example, or increasing such and such investigations. This sort of division here is given by the co-authors of the Global Burden of the Disease study, and who are hoping to adopt it as the WHO model list. But similar lists also exist, for example, by the World Stroke Organizations on what constitutes minimal, essential, and advanced model of stroke care. And then last but not least, it's about increasing awareness and prioritizing neurological disorders high on the political agenda. And one example that is very, very current and very acute is about increasing number of neurological medications on the WHO list of essential medications. Because if they make it on that list, then there's a much higher push actually for those medications to be available in a wider range of settings. So recently, levodopa became an essential medication, but now really big focus is on actually saying, hold on, treatment modifying therapies for multiple sclerosis are not luxury. They should be seen as essential therapy. And then it's about organizing meetings on sort of higher levels. Good example being ministerial meeting on the stroke prevention in Latin America, very recent meeting, quite powerful, or action plan for prevention of stroke in Europe. And there are a couple of other examples listed. I'm sure you'll be aware of initiatives in your local settings as well. But I don't want you to leave this talk thinking, gosh, I need to go and write a national strategy or, establish a big sort of multi-country plan. I want really you to come out thinking that no action is too small, and improvements also happen downstream. And I wanted to give a couple of examples here. And specifically one is about training. It's about our neurology course, which was started in Liverpool by Professor Ben Michael, who you met at the very beginning of this event. And the income from the course run in Liverpool actually provides funding for free training course in Zambia and in Mozambique on neurological diagnosis and neurological assessment. The other photo is from another organization I was involved in, which is called First Aid Africa, which was actually started by a student in Edinburgh where I studied, and it now grew to be an independent charity with its own sort of revenue, providing first aid training, including stroke recognition in countries such as Malawi, Uganda, Tanzania, and also Zambia. And then one of the most recent initiatives in which I was involved was actually working on case definitions. And together with collaborators to whom I would want to extend a warm welcome, because I know some of you are actually here with us today in this talk. So thank you again for your contributions. We worked on case definitions for neurological syndromes, which actually which allows us to show that using those case definitions, non-neurologists achieve similar diagnostic accuracy to neurologists. And we are now hoping to develop this as a tool to not only support the diagnosis and therefore assessment for treatment in different settings, but also to ensure accurate case categorization. And so we can actually actually gather data on neurological disorders, incidence and prevalence. So with that, we're getting to the end, and I want to sort of sum up the key messages from this talk. The first message is that neurological disorders are responsible for a huge burden, and that burden is increasing because our population is aging, and we are not really keeping up with the way that demographics are changing. Number two is that because of this, increasing provision is insufficient. We need to include all the measures that are included in the WHO Atlas. So looking, from prevention to through legislation to strategies, measuring data, but particularly also focusing on promotion on brain health and reducing the number of neurological disorders. And then lastly, I wanted to raise your awareness, make people aware of the WHO IGAP, which is a very powerful document, a landmark action program by WHO. But also, I don't want you to feel overwhelmed. I want you to come out with ideas and thoughts on the fact that every local action is a step in the right direction. So with that, I'm going to hand back to the panel to discuss examples of initiatives and local actions. But in the meantime, as the discussion is ongoing, I also want you to actually engage in the survey that we created in association with this event. You can type the link, and the link should also appear in the chat. And it's a quick survey just asking for your views about IGAP. And we hope that with that, we can understand the situation a bit better and feedback that to our WHO colleagues as well. So thank you very much for your attention. It's been a pleasure, and I hand back to the panel.
Thank you, Arina. That was absolutely brilliant. Thank you for covering the action plan and drawing our attention to the content. The audience has been interacting somewhat in the chat, and we're also grateful for that. They've been talking about the availability of neurological services and access to care in the different settings where they work. In this second panel discussion, I'd like to invite input from some of the other people who are on the panel, directly or indirectly, to talk about the actions that are already taking place regarding neurological disorders in the different settings where they practice. So the first person I'd like to call on to give some input is Gareth. So Gareth is a neurologist, is an infectious disease expert and has experience with meningitis. Gareth, I'd like to get your input regarding services for the treatment of neurological infectious diseases in Africa and in other settings you may be aware of, and what the state of those services are. Do we think they're sufficient? What's going on regarding those?
Yeah, no, thank you for the question. I think it's pretty similar to what was said about the stroke in the sense that, especially regarding neurological infectious diseases, one of the factors that contributes to suboptimal diagnosis is the fact that all the diagnostic tools are not always available. So part of the study that I was working on in the past 2.5 years was looking at the diagnostics as well as early treatment for acute suspected brain infections within the context of Malawi. And what we did find is that a lot of the times neurological infections get diagnosed syndromically. And as a result, the treatment approach is also quite syndromic and empirical. So having the right diagnostics is always a challenge to identify the main disease cause. And I think this is largely attributed to the fact that there's not enough, I guess, resources, and a lot of the hospitals are largely funded by the public health sector. So as a result, there's a lot of underfunding in certain sectors, especially microbiological diagnosis. There has been aid with partner institutions, such as the Malawi Liverpool Walton Trust that works together with the Queen Elizabeth Central Hospital, that has established a culture unit as well as a CSF unit, which helps to identify some of these bugs. So on one end, the diagnostics is poor, but there's also some improvement in certain centers. But by and large, there's still some improvement that could be done.
Thank you. I think that's the broad experience, that there are pockets of improvements that are going on with respect to many of the neurological disorders, but we do need to work on better cohesion with providing these services, especially to those who are least served in the rural areas. The other question to the panel is with respect to just going off of the last comments that you made and the comment that Arina made about what actions we can take to change the state of the field. And the question to the panelists is, are you aware of any neurological campaigns that are taking place? So any campaigns with a focus on neurological disorders that are taking place either to create awareness or local initiatives to improve neurological health coverage. So I'd like to throw that open, perhaps first to Dr. Farumbi.
Yeah, thank you very much, Ma, for that question. Like you mentioned, there are pockets of activities, but not enough to garner a endemic potential that regenerates a national action. But from the top of my head, one that I currently lead, and I've been leading it in the past 2-3 years now, is against dementia. And we made it like, we tagged it dementia, not witchcraft, having seen how a lot of people were stigmatized or publicly mobbed in the city, in places. And we needed to raise that awareness about dementia being a brain disease and not as a result of voodoo or perception or witchcraft. So we led that campaign and we've been leading it up till now, and until recently, because there's a National Senior Citizen Center that was set up by the federal government, the president, and they adopted that slogan at the national level, calling it dementia, not witchcraft. This was supposed to be able to raise awareness and to also change perception and practices around dementia. That is one that I'm aware of. But like I said, there are pockets around. There are some on Parkinson's disease that is even being led by the chairman, Professor Okubadejo, and also stroke. So there are pockets there here and there. But a lesson that we need to take away from here is for all of us to come together and we continue to resonate such that it becomes a music to the ears of the policymakers. Thank you.
Thank you, Tope. I picked up on a comment in the chat from Professor Charfi-Tricky. And it really is true that pediatric neurological disorders form a very large proportion of neurological disorders that we see in many low-income countries and elsewhere in the world. And often the statistics don't take that into consideration. So this is really something to note and to think about when we're thinking about universal neurological health coverage. And the last question I'd like to throw to the panel as we begin to round up is any member of the panel aware of any initiatives from any stakeholders? So we're aware of what the WHO is doing really in leading and guiding member states and helping them to think about formal ways of implementing better neurological health coverage. But are there other stakeholders that we're aware of that are implementing strategies or initiatives to improve neurological health care where we work? And really any member of the panel or anyone, Arina, Adam, anyone else from the organizers can really chip in on this.
I can start in terms of other stakeholders. Certainly, the World Stroke Organization is very active in terms of defining and sort of promoting both prevention and also what would constitute different levels of essential and advanced stroke care. So that's definitely, if someone is interested in cerebrovascular disorders, that's definitely one organization that has strong interest in that and worth looking up on the website.
Okay, thank you, and thanks for that reminder. Also to say that the World Federation of Neurology, the Movement Disorder Society, like she's mentioned, various stroke organizations, other stakeholders, the epilepsy world, there are always trainings to sort of scale up training, recognition, and treatment for neurological disorders that can be accessed by virtually anyone anywhere in the world. However, even when the healthcare, the neurologic workforce is trained, there still remains the issue about access and affordability of services and availability of services, including the diagnostics and so forth. Someone says that, so Lorraine says that in Zambia, they've tried to improve by leveraging teleneurology in public and private partnerships. And there is a hand up. The person can unmute and share their experience as well. So I'd like to invite Bishop Jackson to speak briefly, and then Benedict Michael. Thank you.
Okay, thank you. I was very late because I just want another minute, and I am very happy to be part of this unique initiative. And I pray and I hope that God will increase your innovation. So I raise my hand to appreciate you and also to tell you that do more, God will add on your knowledge, and greater things will happen.
Thank you very much, Bishop, and very kind words from you. Benedict, I'm going to have to ask you to speak quickly or drop your comment in the chat.
I will say it
Go
for
ahead.
1 second. Built off the eye gap, there's a big encephalitis bolt-on that's coming next, and it was only published 2 days ago, the first stage of that. So anyone on the call that's interested, reach out and I will put the link in the chat. Thank you.
Thank you, very kind of you. So I think in summary, we've had a chance to highlight through Arina's brilliant presentation the burden of neurological disorders globally, but also had a chance to peep into the WHO Atlas and become more aware of the things, the issues that are important beyond just the physician and the facilities, but also about the legislation and the political will and other stakeholders that are important in driving neurological healthcare forward and improving the services. We've also had a chance to touch on the challenges that we face across board, and it is apparent just looking at some of the experiences that the challenges are fairly ubiquitous, and we'll need multiple stakeholders working together to make a change. We're also glad to have the driving force of the WHO behind us and behind all the stakeholders, including the governments, and really providing a platform and evidence base for more action to be taken. So I'd like to thank everyone and now invite Greta to continue the program. Thank you.
That was really fantastic. Thank you for chairing this session. We're going to aim to finish each session going forward with the chance to signpost people to some opportunities that we're aware of. Thank you for joining us. The idea is that over the next few months, we're going to increasingly try to use this as a platform to link to new collaborations and link people to opportunities. So please do keep joining us and let us know about anything you think that we could share on this forum. The first thing is a research opportunity. So we recently at the University of Liverpool developed a risk score for seizures and encephalitis called the Seizure Score. We know it works in the UK, but before we can recommend anyone uses it, we need to be confident it works in other settings. So we're inviting people to collaborate, to try this tool in their setting and see if it works. And it only takes, we've got a sort of short form, it takes 10 minutes to fill in per patient. And we'd have full co-authorship or group authorship for anyone contributing cases, kind of depending on how involved you are. And do email Thomas Hughes. The email address is here if you're interested. We'll put this on our Twitter as well afterwards so that you've got reference to everything I'm saying here now. The second thing is a learning opportunity. They're all over the internet, but sometimes it's finding them. So related to neurological infectious diseases, there are free e-learning modules on the Brain Infections Global part of the Global Health Network website. They are free, they're in multiple languages on a growing spectrum of topics. And there's a quiz at the end, and if you do the quiz, you can get a certificate and kind of use that for your portfolio or to demonstrate your learning. So that's a good source of learning, a learning opportunity. And then finally, a funding opportunity. So this is for people a little bit further down the line. For people who've either completed a PhD or equivalent, or have 4 years equivalent research experience, and people can be eligible for this scheme from really all across the world. And it's about funding people early in their career doing research, to develop their research identity and to start asking questions and answering them independently. And it can fund salary and up to £400,000 for research expenses. And I think there's really a move to encourage this to be more of an international scheme, to be inclusive and to be productive and equitable. So do apply and seek support and mentorship if you are thinking to apply from people that you kind of are leaders in your field or in your area. Second to last point is just to say thank you to everyone that contributes to this. We've had some funding from WHO Brain Health Unit and from the University of Liverpool, and it's only possible because people come and chair and speak and join our panel and also participate. The value of what people say when they join these sessions is immense. So thank you for joining us and for sharing your lived experience. And last but not least, we've got another session next month. And it's really building on what we've spoken about today. And so the WHO, as we now know, has released this intersectoral global action plan, which is amazing in its scope and its ambition for neurological disorders. But how do we translate that into action and implementing it in our own settings? And so we've got two great speakers. We've got a chair, Nicola Nchis from the World Health Organization, who can introduce the intersectoral global action plan. And then we'll have a second speaker, Prof. Preziosi, who will speak about a more specific example. So trying to implement change in the world of vaccines and meningitis. So please do join us. I hope the registration link's in the chat. Thank you very much. That's all from me.